key thing is to think as a doctor. So there, we finished section 1. I hope that wasn't too bad. So section 2 is how to think like a doctor so that you can follow what we're doing when we go in the room with a patient. So when the doctor walks into the room and takes the history and does the review of system, they frankly don't care about the narrative of the story. The doctor's not asking a patient how they feel in the same way that a family member would. After getting the general lay of the land, each question that we ask is designed to either increase or decrease our suspicion for diseases which could cause the patient's symptom. And we keep asking questions in ER until we're convinced that the patient doesn't have anything serious or may have something serious, and then we decide what to do. So let's look at this process a little more closely. Okay, so when the doctor walks into the room, the first thing we try to determine is the chief complaint. For example, this patient, my graphic works, has chest pain. So once the doctor has established a chief complaint, the doctor begins thinking in terms of a differential diagnosis. So that's the key phrase for how a doctor thinks, differential diagnosis. Okay, what a differential diagnosis means is that for any chief complaint, such as here, chest pain, there's a list of diseases that can cause a patient to have chest pain. So as the doctor talks to this patient, they're thinking in terms of that list of things that can cause chest pain. So here we see our doctor thinking about the different things that can cause chest pain. For example, pulmonary embolism, esophageal rupture, pericarditis with effusion, aortic dissection, heart attack. And then the doctor's going to take steps by asking questions, doing tests, to either rule these things in or rule them out. So for example, the example chest pain. This is the list of the many things that cause chest pain. And it's the job of the doctor to figure out which of these is the cause of the complaint. Now, as you can see, this list probably has 20 or 30 things on it, and I'm sure you can't read that, and that's actually not important. For many other chief complaints, such as headache or abdominal pain, there may even be more things than this on the differential diagnosis. And for all of those complaints, many of these, we have no test in an ER, there may not even be a test, and no questions we can ask to say if the patient actually does or does not have these things. And you can imagine if an emergency room doctor actually thought about everything on this list and took steps to figure out which of these the patient had, that doctor would see about one patient per shift. So in the ER, we look at things a little differently. And this is the philosophy of emergency medicine. Emergency medicine is not primarily about making a diagnosis. If a patient walks out of our ER without a diagnosis, that's fine. Probably more than 50% of our patients do. Emergency medicine is primarily about excluding and treating serious diseases. And for those people, we exclude serious disease but don't know what they have, the primary doc can pick up where we left off and worry about the rest of the differential diagnosis that's not serious. For many complaints, as I just mentioned, particularly chest pain or abdominal pain, most of the patients who walk out of the ER are not going to have a clear cause for the symptoms. We might say that chest pain sounds like reflux or sounds like a muscle, but we actually don't have any tests to prove that in the emergency room. And so really that patient is walking out without a diagnosis. We just think it's not a heart attack, so it's safe for them to leave. So we don't have to worry about all the things on that list. And patients talk about diagnosis. So I shouldn't be clicking through that. So here again is that differential diagnosis for chest pain we saw previously. Unfortunately for the ER, it's a much shorter list. Okay? In the ER, we're really only worried about these ones in bold. And all the ones that just grayed out, it's because we don't really need to think about them. If we don't get that diagnosis in ER, it's not going to hurt the patient. It can wait a week or a month or a year for them to get a diagnosis. Alright. Sorry, technology issues. So the goal of the ER doctor is to put the patients into one of two categories. Either having something potentially serious, which is all these ones in black here, and us needing to do something about it or admit them to the hospital, or, okay, that slide didn't work. Or actually it just turns out on this monitor you can't even see. I put all the other ones over there. So, I guess that ain't gonna work. So what tools does the doctor use to either lump patients into might have something serious or don't have anything serious? Okay, when they're thinking about the list of things on that differential diagnosis that might cause the patient's symptoms. So, I want you to keep in mind that not all these tools are used for every patient. But our tools are, first, the history, review of systems, social history, past medical history, family history, all include that. Things that we ask the patient. Second tool is physical exam. We look at a person and say, oh, there's an abscess. Done. Okay? Or, oh, looks like you have JVD. You probably have heart failure. And then the third thing is all the tests we do, the troponins and BMPs and chest x-rays and all that stuff. And we don't use all these to rule out every disease. For some diseases, there's no tests. It's only found on physical. For other things, you might only do a test if the history and physical suggest the diagnosis. And more than half the time, history will be the only tool we use to rule out some serious diagnosis. And that's really where it comes into you as a scribe. If the only thing that doctor has done to make sure a patient doesn't have something serious is ask some questions, if that doesn't get documented, then the lawyer's going to say, doctor, there's no evidence you ever thought about this horrible diagnosis this patient could have had. Okay? And so there, for emphasizing, the scribe history is really the one you need to think about. So, we ended the last section by saying all you need to do is read the doctor's mind and convey their thoughts about the diagnoses that they have been considering onto the chart. I hope this brief tutorial that I've helped clear up that process. But let's go through a specific example. And in this example, we'll talk about chest pain. Okay, so here's our patient from before, and I hope this works. It looks like it's working. Okay, so here's you watching how the doctor uses the tools of history, physical exam, and the tests to figure out the differential diagnosis for this patient who has chest pain. Okay? And let's just take one. So there are a bunch of things flashing through the doctor's mind. But let's stop here and show how the doctor might rule out pulmonary embolism using those tools, because that's one of the serious things the doctor might do. Okay? So from the history, the doctor needs to ask, has there been any hemoptysis? It means coughing up blood. Has there been any recent trauma or surgery? And maybe, are you pregnant? Okay. Then the patient, so that's tool number one. And then from this is also comes out of the history, which you'll be documenting. Is the patient on birth control? Have they ever had a DVT or PE before? And then finally, a few things that come from the exam. Is the patient less than 50 years old? Is their heart rate less than 100? Their SAT greater than 94? And no clinical signs of DVT, meaning that they have a blood clot in their leg that might have gone to their lung. Okay? So if all these things are negative, this patient has less than a 2% chance of having a PE. So the only evidence that the doctor thought about and ruled out PE in this patient will be if you caught among all the other review of systems that the patient had no coughing up blood, no recent trauma. So if all this isn't documented, the lawyer can say, doctor, you never explicitly ruled out pulmonary embolism. And if the patient had a pulmonary embolism, your doc's going to be on the hook. Okay? So that's basically how it works. So, mirroring this philosophy to how the doctor thinks that we just talked about, you should look at the chart not just as documenting what the patient has, but documenting that your doctor has used the HPI, past medical history, etc., to rule out all the serious diagnosis in the differential diagnosis that the patient does not have. So the chart is not trying to prove what the patient has. In emergency medicine, we're showing how we use our tools to prove what the patient does not have. Okay? So, as a scribe, obviously, the history, review system, social history, past medical history, and family history are yours. Okay? The doctor, in most cases, is not going to be writing any of that on the chart. So, if you haven't followed how the doctor has used those to rule out these diagnoses, the chart is not going to be defensible. Okay? So in the next section, now that you know how we're thinking, I want to teach you our specific thoughts about certain high-risk chief complaints. And that's the next section of our talk. Okay?